Thanks for joining the RxGeneIQ short patient scenario regarding proton pump inhibitor optimization using pharmacogenomics. PPIs have been associated with many side effects in current literature, such as increased risk of infection, namely C. diff, gastric neoplasia, dementia, chronic kidney disease, fractures, vitamin malabsorption, such as magnesium, iron, B12. So it is important to optimize PPI therapy and reassure that these medications are needed when active on the patient's profile. In the following two patient scenarios, you can observe how pharmacogenomic testing results can optimize dosing of PPIs as per genetic makeup. Let's introduce our patients with rather opposite genetic makeups for PPI metabolism. What does this mean in a clinical setting? Our first patient is a 16-year-old pediatric patient with refractory GERD despite the PPI therapy. As you see here, we have BID PPI, so we gave the dose a pretty good chance. It's optimized here, in addition to Zantac at night. And the symptoms continue, and they're not controlled. She recently complained about the chest pain, racing heart rate, around eating, decreased appetite, and not being able to attend school. So the provider decided to optimize the anxiety medication using pharmacogenomic testing to tailor the therapy. Currently, she's on Lexapro, but she does not have control on the anxiety, as you see from the symptoms. She is, per her results, per pharmacogenomic results, she's a rapid metabolizer for cytochrome P452C19, which explains why Lexapro therapy is not working here. The failure could be due to her genotype for being a rapid metabolizer and for metabolizing this medication too fast. And so the therapeutic levels are not high enough to be effective. We recommended switching the medication altogether, and venlafaxine was chosen. The patient, this is a very successful deprescribing episode using pharmacogenomic testing, as the patient stopped having any GERD symptoms and was able to be off of PPIs on just venlafaxine therapy. The other patient also had an ultra rapid metabolizing genotype here, as you see. But it is the use of this pharmacogenomic testing was completely opposite of the patient previously mentioned. This 36-year-old had a refractory GERD for 5 years, many years of non-effective therapy with PPI, and recently her symptoms got as severe as vomiting and epigastric pain. She also has an active ulcer, which necessitates ongoing PPI therapy at the optimized dose that is mentioned here. As per her genotype, she's an ultra-rapid metabolizer, and we consulted here. We always consult this very reputable reference, PharmGKB, for various genotype, phenotype, and the recommendations they have. These are actionable recommendations that we can use on a day-to-day basis in a clinical setting. Here, the action was to increase the dose by 50 to 100%, and so we ended up recommending 80 milligram BID, which took care of the problem of having vomiting, epigastric pain, and multiple symptoms. We hope these cases were useful to you. At RxGeneIQ, we value our collaboration with providers and their referral. If interested, please feel free to view other patient scenarios or sign up to be on our mail list for future patient cases.